the following is an assessment and treatment of the lumbar region that one might encounter at our office. Assessment of bony landmarks for symmetries and asymmetries to gain structural awareness of the skeleton. Comparing movement of associated asymmetries to assess for correlation with movement problems. Here we are assessing the basic movement potential of the sacroiliac region. Assessing for movement capacity of the rib cage, looking for key indicators for impaired movement potential within the rib cage, which can magnify forces impacting the function of the lower back. Assessment of the thoracolumbar junction, a key rotational center that is oftentimes dysfunctional in patients with lower back conditions. Assessment of active range of motion to collaborate our visual inspection with areas of immobility. Guiding the patient through full spectrum of range of motion for pain provocation, as well as to assess for movement obstructions or areas that move excessively. Moving into an extension quadrant to assess for closing motions of the lumbar vertebral facets, soft tissues, and otherwise tolerance to being able to extend and rotate. Assessment of the frontal plane, a key motion potential in patients with lower back problems, often found to be hypermobile. More specifically evaluating movement potential in the lumbar spine, assessing for movement potential in the lower lumbar segments through more specific flexion and extension movements. Identifying a more specific restriction in the thoracolumbar junction. Patient reporting for evidence of associated discomfort while palpating this area with movement obstructions. Prone lying assessment for provocation and motion assessment of the lumbar segments, trying to identify specific areas that are sensitive and what motions they're sensitive into. Identifying these will help direct our exercise prescription as well as our manual therapy intervention. Spring testing on the lumbar segments, also looking for areas of provocation areas that move excessively, areas that move poorly. More specific assessment of the motions of the lumbar segment, passive intervertebral movements, as well as looking for areas of, in this case, instability or hypermobility. Identifying one-sided opening and closing restrictions with passive movement through the hips. Assessment of the motion of the thigh, the hip. First, the soft tissues of the front of the leg with the knee bending, and extension capacity of the hip joint. Very commonly to find a hip that is not moving well in patients with reoccurring lower back issues, creating a fulcruming and torque into the lumbar vertebrae. Rotational movements of the hip are identified, looking for restrictions in the joint and as well as the soft tissues. Additional range of motion assessment of the hip. The hip should be able to flex to roughly 120 degrees prior to detecting movement in the lumbar spine. In this case, identifying that the hip flexes with a mild restriction into hip internal rotation. Testing for the engagement of the abdominal or trunk muscles, core muscle function, while resisting the hip. A key association of where the body needs to have automatic core engagement. The left side was clearly impaired. Treatment of the identified motion restriction at the thoracolumbar junction. Assessment of the myofascia thoracolumbar junction, treating using a cascade of soft tissue mobilization techniques to complement the manipulative therapy performed in the motion segment. Soft tissue mobility is a key and oftentimes underlooked component of reoccurring back issues. Identifying the tissues and their ability to slide vertically, deform perpendicularly, or to be able to otherwise bend and stretch. Restrictions that are commonly not able to be treated using foam rollers or myofascial techniques can be more clearly treated and appreciated using manual techniques. The addition of movement and active contractions helps to localize the restriction within the soft tissues, encourage their change and relaxation, as well as improve the patient's sensory awareness of the region. This is known as a functional mobilization. Following up on the identified restriction of the left hip into rotation, here treating the hip joint with a back to front pressure to keep the hip resting neutrally within its socket. A thrust manipulation is performed as the restriction is identified to being safe, but also strongly limited in its ability to move posterior from the back to the front. Identifying and treating again soft tissues of the iliac crest and the rotators and the glutes of the hips, which commonly become spastic or tonic when the hip joint is dysfunctional. Incorporating active movement, resisted movements are key to successful intervention. Identifying for lumbar segment motion with the active contraction of the knee flexion. Changing the fulcrum from high to low, identifying for asymmetrical movement in the lower lumbar segment, and taking the restriction closer to its end range by localizing through the legs in these further end range positions to treat out the dysfunction more comprehensively. Following into more weight bearing is a key component to successful treatment of any body region. Looking for asymmetrical movements or otherwise identified restrictions earlier in the exam, and ensuring that we're treating each dysfunction in at least 3 different positions to maximize the impact that we're having on the area. Pressure is applied to the right side of the thoracodorsal fascia region, thoracolumbar junction, into the barrier of greatest restriction. The patient actively sits back to engage the barrier to help in the mobilization process. Assessment of the patient's ability to stabilize this region by applying a pressure on that segment and asking the patient to remain still. Identifying whether or not there is in fact segmental control and working to enhance that through resisted movements. This enhances the patient's awareness as well as the integration of the movement back into the movement system. Addressing the front of the lumbar spine is a key and often underappreciated component of lower back pain patients. Oftentimes we can identify soft tissues of the abdominal wall being not mobile, perhaps from scarring or adverse holding patterns. Additionally, the fascial connections into the visceral compartment can negatively impact the motion capacity of the lumbar segments and often cause them to become fixated or hypermobile. This is very common to be found in patients who have had abdominal surgeries or abdominal traumas. Additionally, individuals with irritable bowel syndrome or colitis can often find that there are adhesive tissues within the visceral compartment, negatively impacting the lumbar vertebra. Identifying deeper motion restrictions in the lower lumbar spine, checking for the ability for the vertebral bodies to move from the front to the back. A key fixation often is unlocking the lower lumbar vertebrae from an overly compressed or stuck position where they are stuck forward and cannot move to the back. This often implicates a lumbar disc, which can be historically swollen or loose, and allow excessive forward translation of the vertebra, known as a anterior listhesis. Always after establishing mobility within a movement, we take those same body parts to their position of where we've achieved new motion and work to reestablish a automatic firing of the local trunk muscles to help stabilize and otherwise encourage the active participation and recovery and integration of those areas. Here we're using a chop motion to the left and a flexion diagonal to the right to enhance the firing capacity of those lumbar vertebrae, stabilizers. Addressing the ilium's motion on the sacrum in the sacroiliac region, working with my hands to improve the play of the soft tissues around the joint, as well as enhance the motion of the compartment of the back of the hip. Moving right in again to neuromuscular re-education. This pattern is called the flexion adduction external rotation pattern, which is one of our developmental sequence basic movement patterns that we often lose and can use to help reintegrate after a mobilization technique, ensuring that those muscles can work appropriately through the range of motion. In this case, this is not an acute lumbar injury, and he can tolerate this external load with success, working in the opposite direction, the extension pattern, to help the brain recognize the difference between flexion and extension and be able to work in and out of both ranges. Moving again into more complicated positions, asking for more co-contraction and demand, getting the shoulder blades and the trunk to work in this position is key to moving through your rehab progress to ensure that these patterns can be reinstated progressively further in the developmental sequence. This particular milestone is crawling. This phase of crawling would be the same motor patterning that would be required for effective forward walking in your gait cycle.